So welcome back. Here's chapter 24, Hematologic and Renal Emergencies. So blood and kidneys, they go together. Who knew? So blood, it is its own organ system. Clotting, which controls bleeding, right? We deliver oxygen. We pull carbon dioxide and other wastes away. So it's a transportation medium. The system is the vascular system. The transport medium, blood, right, carries clotting factors. It carries fibrinogen. It carries red blood cells to carry oxygen, carries white blood cells to fight infection, and it brings all that trash back to the appropriate system for removal. It's all suspended in plasma. So if you scrape your hand, you're running and you fall, you scrape your hand and you get that little bit of road rash on your palm. That clear fluid is the plasma. Now, there are medications that affect this stuff. If you're anemic, chronically anemic, you've got low red blood cell counts, iron helps with that. Antibiotics certainly help white blood cells do their job better. Blood thinners like aspirin, Coumadin, Plavix, or Lovenox help keep the platelets from being as effective. So we call them blood thinners, so they don't clot as easily because they have some underlying medical condition like an irregular heartbeat, atrial fibrillation. So with AFib, they are more likely to throw clots and have strokes and heart attacks. Okay. Now clotting. So there are all kinds of clotting factors. I am not an expert in this. I was teaching a refresher one day and I made some comment about clotting factors. And one of my students in the class who was in her senior year for pre-med, I think it was, organic chemistry, whatever it was, microbiology, jumped up and was all excited and spent 20 minutes listing out like 15 different clotting factors and how they worked. And we were all just sitting there lost, in awe, mind you, completely in awe of how brilliant she is as an EMT. But when she got done, I couldn't even get a word in edgewise. When she got done, I was like, thank you, don't ever do that again. It is a specialty, right? Just to understand that there are factors and there are different disease processes that affect those factors. And we'll touch briefly on a few of them. But once these factors are activated, we start to get clots forming. They plug the holes that are made so that we don't bleed out. Now, coagulopathies, abnormal clotting of blood. So you see this in trauma patients with hypothermia. You see it with acidosis, where they activate all these clotting factors and they throw all these clots, form all these clots all over. And then the body goes, oh my God, what have I just done? And it releases its own clot busters, tissue plasminogen activators. And they go out and they break down all the clots. Well, now we can't make any more. And so we have this horrific bruising and bleeding. And it's very common. Like I said, with trauma patients who get cold, who get acidotic, and who get hypoxic. Okay? So that is like the worst form of coagulopathy. Liver disease, liver failure, you see different coagulopathies, bruisings and whatnot. Hemophiliacs don't clot well. And von Willebrand's is a version of this, and I don't remember specifically the different factors that these all affect. I know my daughter's got von Willebrand's. She bruises easily. Menstrual cycles are heavier because of these things. So a lot of females, that's how they diagnose this stuff. They're 9, 10, 12 years old and they're starting to have periods, and they're heavy periods. They end up on hormonal therapies to help limit those menstrual cycles. So I already mentioned atrial fibrillation. When you have a nice, normal, regular heartbeat, normal sinus rhythm. The blood flow is consistent and smooth. When you have atrial fibrillation, you have pauses in that blood flow. Every time blood pauses in behind a valve, specifically in your heart, that blood can thicken a little bit. And next time it gets caught in one of these little valvular jetties, thickens a little bit more, and then it hangs up on a piece of plaque and starts to clot. Okay, so they end up on blood thinners. It might just be an aspirin a day, but it could be heavier duty injectable meds or oral meds. So when they get hurt, they're at more risk to have life-threatening hemorrhage. Anemia, low red blood cell count. So you can have chronic or acute. Acute would be that GI bleed. It could be that lacerated artery, right? That makes sense. That is an acute, right now, holy crap, we're gonna die anemic event. Chronic anemia, already mentioned excessive menstrual periods. Slow GI bleeding. Now you can have a big GI bleed and become acutely anemic, or you can have this little tiny one. You have no symptoms of it. You don't see any blood in your stool. You're not vomiting blood. But over a period of a week or two, you just, I just don't feel good. I don't have any energy. I climb the stairs and I'm worn out. And I feel like I can't, I got to stop and catch my breath. Well, what happens, we go to the ER, you get your blood drawn, and they go, oh, you're anemic. The ER doc walks in and pulls on his glove, and he's got a little card, and into your rectal vault he goes, comes out with a little bit of smear on his finger, puts it on a card, and they put a couple of drops of stuff on it, and it comes out black. You've got blood in your stool. Okay, hey, you get referred to GI. The GI docs, you get scoped and whatnot. Now, you can be chronically anemic and need blood transfusions. Okay, so chronic or acute, you could end up having to have some blood transfusion. Sickle cell, primarily African Americans. However, some Indians and Middle Eastern. I've also heard of some Central American groups that are also at risk for this. Red blood cells are supposed to be round. Your capillaries are round, and they are exactly one blood cell in diameter, so that the most surface area possible is available for gas exchange. Now you take this round capillary and you make a sickle-shaped cell that's bigger, and they kind of twist and turn. But what happens is they clump together and they basically form a clot. They form an occlusion. So they have sickle cell crises, which is an occlusive crisis, but also they have a chronic form of anemia. These sickle cells have a lifespan of only like 25 or 26 days. I don't remember the exact number off the top of my head. And most red blood cells are about 75 days. So you can see they will become, because your body plans on red blood cell production for the normal red blood cell. So if you're losing them sooner than we're making them, you will become anemic. So if you have one of these occlusive crises, right, it could be in the spleen, cause damage to the spleen. Pain, if you clump in an area, that area distally to that occlusive clump becomes hypoxic and you get pain, a lot of pain. You can have pain in your chest, priapism, right? Because you have this occlusive clump and now blood's still going into it, but depending on where the clump is, blood's not being allowed out of it. Stroke, jaundice, you're having these events, it's affecting your liver. 1 in 12 African Americans has the trait. It does not mean that 1 in 12 have sickle cell crises, though. A lot of them never do. Now, I live in the state of New Hampshire. My classes are in the state of New Hampshire. State of New Hampshire is still primarily white, right? I mean, there's That's not a racist statement. That's a fact. We, when we say we have a minority population in New Hampshire, they are in fact a minority still. If I worked in Birmingham, Alabama, or Baltimore, Maryland, I'm a lot more likely to see sickle cell because that population base is more even, right? State of New Hampshire, it's very rare for us to run into, unless you're in Manchester, Concord, that 93 corridor down through into Lowell and Lawrence. It's pretty rare for us in New Hampshire to run into a minority, much less a sickle crisis. Okay, so we really need to stay on top of this because for us, it's a lot rarer event. So we need to be able to recognize it because it's a big deal. It's a big issue. Oxygen, ABCs, right? Make sure we have good airway. Make sure we're oxygenating, ventilating, and perfusing well. If you do a stroke assessment and they're positive for a stroke, it may not be a clot per se, right? Fibrinogens did not get in there. It did not activate clotting factors and form a clot, but you've got a clump. We need to treat it the same way. If it looks like a stroke, treat it like a stroke. They have sickle cell. They're having chest pain. They're having ST elevations. It may not be a true clot as we know it, but it is a clump, and it needs to be treated that way. Okay. So kidneys themselves, 2 kidneys with 2 ureters leading out to 1 bladder with 1 urethra leading out. So that's the way I remember it. 2 kidneys, so therefore ureters are plural. 1 bladder, urethra is singular. Filters blood, removes waste. Fluid balance. So your kidneys will release chemicals to pull fluid out of the bloodstream, to diurese, to get rid of it. Based on, oh, I've got too much fluid in my bloodstream, the kidneys go, oh, hey, I can get rid of that. Versus, wow, I'm dehydrated or I'm hypovolemic. I'm not going to pee. I'm going to shut down my urination so that way I can retain fluid for fluid balance. And for acid base, if we start to become hypoperfused, right, our body starts to shut off blood flow to our skin first, to our gut second, to our extremities next. And we start to go into anaerobic metabolism and we start to give off hydrogen ions and become acidotic. The kidneys go, whoa, I got this. And they release bicarbonate. HCO3, bicarbonate, comes out and combines with hydrogen, which is an H, which gives us H2CO3 carbonic acid. Hydrogen has a pH of about 3. You combine H with HCO3, you build H2CO3 carbonic acid. That pH is roughly 5. It's not great, right, because our pH is 7.35 to 7.45, but it's a lot better than 3. And then our buffer system can kick in. That's part of the buffer system, but the rest of the buffer system can kick in and boost our respiratory system, boost our respiratory rate. And if we breathe off, we are breathing faster and we are exhaling more CO2, then that H2CO3 will get broken up into H2O and CO2, right? You've got 2 H's, H2CO3. So H2O and CO2, you've got all those 2 H's, 1 C, and 3 O's, but you can split them up and now you can exhale them. And that helps shift our body back up into the correct acid-base balance. So as far as diseases, mild to life-threatening, UTIs, mild to life-threatening. Bacteria into the urinary system, into the bladder, if left untreated, can certainly end up in the kidneys, pyelonephritis. you can have a mild UTI, right? It hurts. I don't feel good. I'm worn down, obviously fighting infection, right? All those kind of symptoms that go with any infection. And you get put on an antibiotic, and a few days later you feel good, and 10 days later it's gone, right? Perfect. Or you could become septic from a UTI. Septic is a life-threatening event, okay? So UTIs. Elderly females, I mentioned this in the behavioral chapter, but elderly females, the number one cause of altered mental status is a UTI. Okay? Kidney stones, not life-threatening, although you might wish you were dead. Calcium forms up these stones within the kidney. A lot of people have kidney stones floating around in their kidney. Okay, I had a CAT scan a couple of months ago because I had some gastritis. I ended up in the ER with some belly pain. And there were a couple of small 1 millimeter stones floating around in my kidneys. Okay, as long as they don't get any bigger, and as long as they stay in my kidneys floating around, I'm fine. When they end up into the tubules that lead into the urethra, into the ureters, I'm sorry, that's when it blocks the flow and causes local irritation, and then urine starts to build up, and you get a lot of pain. That pain can go from your flank all the way around to your groin, penis, testicles, vagina, whatever, into those organs because they share pathways. Therefore, they share a nervous system also, so you can get referred pain all the way up and down that system. Okay, nausea and vomiting, very common because the pain is so severe. It triggers that chemical response. You become nauseous and you puke. So you're obstructing bladder flow. You can also have it as a result of one, two, three. So patients with urinary catheters. So catheter is a tube, a small rubber tube that goes in through the urinary meatus, up through the urethra into the bladder to allow drainage of the bladder. We see a lot of older guys with this because they have enlarged prostates, and it makes an obstruction of that urination. It obstructs their ability to urinate, and so they get urinary distension and hurts horrifically, right? So they end up with a Foley to help keep their bladder empty. Neurologically, you could have an event where, like a friend of mine, when he was in his 20s, had surgery on his back. Like he had a mass on it somewhere in his retroperitoneal space, and they had to go in through the front side because of his spinal cord was so close, and they nicked a nerve, and it affected his ability to urinate. So for the last 30 years, he has to self-cath every day in order to urinate. So drains urine. It may be a suprapubic Foley as well, which instead of going in through the urinary meatus and the urethra, gets put in through the abdominal wall. We sometimes see these patients in EMS because they've pulled them out, like they're in a nursing home and they pulled out their suprapubic catheter. Well, they have to go into the ER so that one of the nurses there can slide it back in. Or the urinary meatal Foley gets pulled out also. The problem with that one is it gets usually pulled out with the balloon inflated, and that big balloon comes out through a tiny little hole. We tend to see some blood with that. The other thing we see, urinary tract infections, because you now have a tube straight to your bladder. Bacteria follows that tube fairly easily. Okay? And the trauma, so like I said, you pull an inflated balloon out, you'll get a little trauma. As far as renal failure, Kidneys are losing their ability to filter and remove toxins. Acute failure. So right now, kidney failure is either shock or toxins. Some form of a chemical poisoning. Chronic is typically diabetes and some mix of hypertension. So when we talk about recognizing shock, especially compensated shocks that you know they're going into shock, what we're trying to prevent is renal failure. Okay? So end-stage renal disease, can be caused by acute failure or as a result of chronic failure. These are the folks who end up on dialysis. So two forms of dialysis, hemo and peritoneal. Hemo is they've got the big shunt. We'll see some pictures of this. And they go in 3 times a week to the dialysis center. And peritoneal is they have a tube in into their abdomen, and it gets done at home. And they, hook up a giant 3,000 ml bag of fluid with different chemicals in it based on what their chemistry show. And it gets drained into their stomach, sloshes around a little bit, washes into their abdomen, I should say, not their stomach. Sloshes around, kind of cleans off the outside of the organs, and then gets drained out. That's kind of a stopgap. It helps delay, if they catch it early enough, it helps delay the need for hemodialysis. And hemodialysis, you got to go in 3 times a week to a dialysis center where you sit for anywhere from 4 to 6 hours in a recliner in a room full of people who are in a mix of anger, denial, crankiness, and happiness and friendliness. And you can sit hooked up to a machine that drains your blood out and filters it and puts it back in, and it's exhausting. So if you can do peritoneal dialysis, most people are certainly happier doing it at home. About 90%, though, go to specialized centers. They are coming up with home dialysis machines. Super expensive, pretty rare still. And so you can get your dialysis done at the house. It'd be great. We take a fair number of these dialysis patients to dialysis. They're too weak and too sick otherwise to get in and out of a car or in and out of a wheelchair van. EMS takes them by wheelchair van also. And we take a lot of them from nursing homes. They go in for the dialysis, we take them back. There are different negative terms that you'll hear for it, like a renal roundup, for example. Some of the big cities, they have renal trucks, dialysis trucks. That's all they do. 8 hours a day, 10 hours a day. They have the same 10 patients, and it's, say, in the city of Boston. This nursing home to this dialysis center, and you just back and forth, back and forth, back and forth, back and forth. Those would be tough trucks, I think, to work. So hemodialysis, you can see here, it gets taken out. They monitor pressures. It goes through a pump. They get a little bit of heparin in there to prevent clotting while this is going on. It gets dialyzed, which means it pulls the excess fluid out. They measure the pressure going back in. They trap any air, and it goes back into the bloodstream. So anytime you have these little centrifugal pumps, there are little microscopic air bubbles that get formed. So that's why they collect those on the way back in. So 2 types of access for this. You can have a central IV line like you see here, where this is usually more of a temporary. So when they put in a shunt, it takes about 30 days, if everything goes well. It takes about 30 days for that shunt to heal and be usable. So in the meantime, they have to have dialysis. So you can see this has a red and blue port, goes up underneath the bandage, which will, that white edge that you can see, that's sutured into the skin. If this one burrows under the skin, you can see the line goes up and it goes into the, probably the internal jugular vein. Others will be put into the subclavian vein, which runs right under the clavicle. And then this is a shunt. So what they do is they go in surgically and they combine an artery and a vein together. And it's kind of a big, ugly looking thing. It could be in their forearm or it could be in their bicep. Do not take blood pressures on the side of a shunt. There is the possibility that we can damage that with our blood pressure cuff. And then they need to have a central line put in. They need more surgery to have another shunt put in. Peritoneal, again, you see the tube, fluid gets hooked into this, and they do this themselves at home. Every once in a while, it might be weekly, they have to take a sample of it and have it looked at in the lab, and they can adjust their renal docs can adjust what the fluid is and what the balance of fluid is. Okay? So it gets drained off, sometimes by gravity, sometimes by machine. Now, medical emergencies, we see them because of the fact that they have renal dysfunction or because of a treatment issue. So like a lot of times we'll go to dialysis centers because they won't stop bleeding, right? Maybe too much heparin was into the blood on the way back in, and they just can't get the shunt to stop bleeding. And so they end up in the ER where they just keep direct pressure on it and they watch them until it stops bleeding. But they can't sit in the dialysis center for 3 or 4 hours because, hey, we need the chair. The ER needs the bed, but whatever. So we go in and do that. Worst case scenario, tourniquets, but usually just direct pressure. They use a clamp right over the site, keep the clamp on. They'll take the clamp off every once in a while. Oh, it's still bleeding. They'll put the clamp back on. Leave the clamp on. If you have to, you could do a hemostatic dressing like Quick Clot, and then the clamp, or you could do a tourniquet if you absolutely had to. Then you got to remember they still have their underlying problems. They're still diabetic. What's their blood sugar, right? They may have high blood pressure. They may be on meds for high blood pressure. And now the dialysis center took off a little too much fluid and they're shocky, okay? The other things we see for them is CHF. So remember, they're taking excess fluid off. If you can't take that fluid off, then fluid builds up in your bloodstream. You have a history of hypertension, you have an enlarged heart, you have a history of CHF, you have too much fluid in your system, it backs up in your lungs. We see this fairly commonly with these folks. Swollen ankles, swollen hands, but when it backs them to the lungs, they're short of breath. CPAP for these folks right away. Why do we see them? Well, the way these people do dialysis is 3 days a week. So let's say Monday, Wednesday, Saturday. There's always a 72-hour gap somewhere in there. So Monday to Wednesday is 48 hours. Wednesday to Saturday is 72. They might go Monday, Wednesday, Friday. Friday to Monday, 72 hours. That 72-hour period, right? Sir, you're short of breath. When was your last dialysis? It's now Monday morning. Well, it was Friday. I'm supposed to go this afternoon. It's that 72-hour gap. So they're a little behind the curve fluid-wise. How have you been this weekend with your fluid intake? Well, I may have had a little, I had a couple of beers I shouldn't have. Or, well, I drank too much water. Okay, you're in CHF. Here's your CPAP. They come out of dialysis. They're weak. They're dizzy. Their electrolytes are off, either too high because they haven't been when they should have, or too low because they pulled a little too much out. So they missed dialysis. Why would you miss dialysis, right? This is keeping you alive. You feel like shit. You've got flu-like symptoms. You just don't have any energy. And so you're like, well, I know I'm supposed to go today, but I'm going to skip today and I'm going to stay home because I feel like crap. They skipped it. ABCs. Okay? Oxygen is needed. CPAP is needed. Keep in mind their electrolytes may be high, like their potassium, for example, they could go into BFib. So have your ED ready. And transport facility capable of dialysis. That's great in theory. Frisbee used to have a dialysis machine in-house. I don't know if they do anymore. I know Wentworth Douglas can. I know Portsmouth can. The small community access hospitals don't. They have to ship them someplace to a bigger facility. So if you've got a choice and, they miss dialysis, and, I'll use the town of Wakefield as an example, Wakefield, New Hampshire. They're, 20 minutes to Huggins Hospital in there, 30 minutes to Frisbee. You're better off taking them to Frisbee, because they can do dialysis there, right? So take them to the right place. If you're not sure, call the ER. Hey, look, I'm 20 minutes from your location. They missed dialysis yesterday. Can you dialyze? No. Okay, so you call Frisbee. Can you? No. Okay, Wentworth Douglas. Yes. Great, go to Wentworth Douglas. Okay. Now, the bleeding, like I said, we already talked about clotting issues and hemostatic dressings, direct pressure tourniquets if you need it. They can get infections, especially with peritoneal dialysis, because you've got an opening into their gut. So peritonitis, a lot of belly pain, fever, shocky. ABCs, control bleeding, as we've talked about, oxygenation if they need it. Treat them for shock. So keep them flat, keep them warm. If you think, right, they're a home dialysis, peritoneal dialysis patient, bring one of their waste bags with them, okay? So they can do some testing on that in the lab. Transplant patients. Kidneys are the most commonly transplanted organs. 16,000 a year, I bet you it's even more than that. I think they would like it to be about 3 times as much. There just aren't enough kidneys out there. I'm a donor. I wipe my motorcycle out and take my head off. Hey, yeah, have my kidneys, okay? I don't need them anymore. So I'm a big fan of organ donation. They end up on medications, though, because you got to think about their immune system. Their immune system sees this foreign kidney as an invader, like a giant splinter, and it tries to get rid of it, right? So they end up on immunosuppressants. So you're on a drug that suppresses your immune system, you're at risk for every other infection on the planet. So you've got a person who gets transported 3 times a week for dialysis. She calls today because she didn't go yesterday. She can't breathe, feels like she's going to die. Is that a legitimate complaint after only missing 1 day of dialysis? Absolutely. 25 years ago in Somersworth, we had this lady who went to dialysis on her own 3 times a week. She was a Monday, Wednesday, Saturday. And the reason I remember that is I used to work a Friday 24. And about once a month, maybe every 6 weeks, on Saturday morning about 5 a.m., we get the call because she was in congestive heart failure. Because that 72-hour window was too much for her sometimes. And I don't think she was doing anything wrong. I just think that, she probably should have it every 48 hours. There's just not enough facilities around to be able to do that for everybody, though. All right, so hematology, nephrology, a very basic overview of it. If you got any questions, shoot me a text, shoot me an email, leave a comment at the bottom, and I'll see what I can do about getting back with you. Okay, or as soon as I can, I should say. Anyways, thank you for joining me today from sunny Cape Canaveral, Florida.